Alrighty, good morning, everyone. Almost afternoon. Today we are joined by Miss Heather Hallett, who is our healthcare industry consulting leader here at SAS. And today she'll be talking to us about improving operational efficiency in the healthcare workplace. If we have time at the end, feel free to ask some questions, and if not, you can catch Heather over at the Healthcare and Life Sciences booth after the session. All right, take it away.
All right. Thank you so much. And again, good morning, good afternoon to everyone, and thank you for joining today's session on improving operational efficiency in the healthcare workplace. As mentioned, I lead our healthcare industry consulting team, and we have a bunch of specialists on the team that support not only our payer clients, but also our provider clients. And unfortunately, one of my partners in crime, Ben Murphy, who maybe some of you have met, he couldn't join me today, but he's our resident data scientist, as well as he is our operations research expert, and he's also available to meet up with you subsequent to the Innovate conference today. Today, you can expect really two demonstrations to improve operational efficiency in the healthcare workplace. The first demo really focuses on forecasting demand for clinical staff, and we're going to be looking at how to optimize a schedule with the right resources. And then the second demonstration that I'm going to perform today is really addressing the healthcare workplace beyond the four walls of a hospital. As you know, we're really trying to think about shifting care upstream, and we also need a way to optimize resources who are traveling out to deliver care mobily. So to set the stage for today's discussion, and just by a show of hands, who's sitting here today that's actually worked in a clinical care unit or has worked specifically in an ICU unit? I see a couple of hands up. So some of you have experienced the chaos, right? Well, my background is actually as a nurse, and I actually performed nursing in a critical care ICU, one of the biggest ICUs in Detroit, Michigan. We were a level 1 trauma center, and there was not a dull moment, believe me, at all. Our unit was really separated into kind of two sections. 20 beds of the ICU was dedicated to those trauma patients, and then the other 20 beds were dedicated to our cardiovascular ICU patients. And on average, just from those 20 beds, we would transition about 15 patients out that had open heart surgery and transition 15 patients in. So you might imagine that not only caring for critical care patients and managing the transition as they came in and out of the ICU, there was a lot of stress in being a manager on that type of unit. And staffing was always a problem, especially on Friday and Saturday nights when we had a lot of call-ins. And I don't know if many of you attended Dr. Michel's presentation on the main stage this morning, but he was talking about how accuracy and transparency with AI is so important because the decisions that he's making are life and death decisions. Well, I just want you to know that staffing decisions are life and death decisions as well as a critical care nurse manager, because if I don't have the right nurses with the right skills to take care of patients and to take care of patients that perhaps are the criticalist of ill of the patients, then that could be a life or death situation. Working in the intensive care unit was chaotic just to begin with, but the phone calls were just unrelentless, with the emergency department putting pressure on me all the time to take patients in, as well as the recovery room really putting pressure on me to take those surgical patients in. And there was a lot of things that we tried to do to solve this problem just from a manual or operational perspective, and it included doing things like having mandatory staff meetings with all of the managers so that we could really look at staffing in a very manual way to see which nurses we could steal from different areas that could support the patient demand. We also had emergency bed meetings, and today I'm happy to say that there are more operational improvements that are occurring because I'm seeing a lot of new roles emerge in hospitals and health systems around patient flow coordinators, as well as operational analysts are actually being applied to solve this particular problem. The other thing I used to do was I used to do what I'd call a walkabout, or I'd send one of my techs to do a walkabout. They'd go to other units to see if there was beds available, so if we had people ready to be discharged, we would know if there were beds available. And these nurse managers on other units, they oftentimes wouldn't let me know that they had beds available because they didn't have staff to take care of the incoming load and the demands of patients coming in. So a huge problem that I dealt with when I practiced clinical nursing, and unfortunately it's still a huge problem that exists today in our healthcare organizations. So the problem that we want to solve, or the question that I want to answer for you today is, can we really create a new management tool which will allow clinical leaders to forecast patient arrivals and recommend staffing resources to meet the variable demand throughout the day? And the answer is yes. Yes, we can with SAS. And looking at workforce demand forecasting, it's really an essential component to predicting future staffing requirements based on various factors. By analyzing those historical trends, census trends essentially, organizations can really better align their workforce with anticipated needs. So the objective is really, how do we know how many staff we're going to need to meet the demands of the forecasted patient population that we can expect? And in this case, it's going to be in an ICU scenario. And can we skills match the right nurse to the right patient? And can we also suggest maybe a schedule that includes nurses that are maybe lower cost or getting a lower hourly wage? So as we build out these workforce demand forecasting models, there are rules that you would incorporate into them. For the demonstration today, we didn't put in some of these sophisticated rules, but we could add in rules around things like nurses can't work more than 16 hours, or maybe nurses can't work more than 5 days in a row as examples. So what kinds of data are actually required to do a workforce demand forecasting? So 4 pieces of data that we really use for the demonstration today. You would definitely need to know the historical ICU patient counts. So you need to understand how many patients on a daily, weekly, and hourly basis were actually admitted to the intensive care unit. So in this case, for the demonstration, we actually looked at and modeled out some admission, discharge, transfer data so that we could know at any moment in time what the census was in the particular department. The other thing that we needed is we needed patient acuity scores. So for those of you that aren't familiar with an ICU, the sickest of the sick patients, they get one-on-one nursing care. Sometimes they get two-on-one nursing care. And for those that are a little more stable, usually a nurse can take up to 2 patients. In addition, some of those patients, they could be requiring assistive devices. And this is going to come into bear when we get into the demonstration, but some nurses in the ICU are certified to take care of patients that have these assistive devices. And 2 of them that I want to call out are what we call intra-aortic balloon pumps, and the other ones are what the other assistive device is called extracorporeal membrane oxygenation. I always joke and say you can use that at the cocktail party tonight, that you learned about this clinical term today if you've never actually worked in a clinical care unit. But both of these devices are for the sickest of the sick patients, which helps them pump blood and oxygenate blood. And nurses are certified, specialized nurses are certified to take care of those particular patients that have those assistive devices. And again, I'm telling you this because this is going to come to bear when we get into the actual demonstration. The other data that we needed is we needed historical staff schedules. How many nurses did we actually have to meet the patient demand in the past? We also needed present day schedules so that we could actually look at that and determine how many nurses are we going to need in present day. Other pieces of data, yes, we could generate other pieces of data, clinical data, to really generate those patient acuity scores. For the demonstration, we just randomly assigned acuity scores, but you definitely would want to do some predictive modeling around who's likely going to need that one-on-one care and who potentially is likely to require one of those assistive devices. So let's have a look at the dashboards and jump into the demonstration right now. So we're using historical patterns in the data with the intention that this is to inform future capacity. So how did we do this? We actually used a time series forecasting model called ARIMA, which stands for Autoregressive Integrated Moving Average. And it's a popular statistical method which is used for time series forecasting. And if you look at the visualization here, the left-hand side of our dashboard, you're going to see that the number of patients in the ICU were forecasted for the upcoming 5-month period. In this case, we created our demonstration for it to range from the months of December through April 2025. So you'll see that the census, it was pretty steady for the months of December, or predicted to be fairly steady, forecasted to be steady for the months of December through about March, but then you're going to see that influx in our census, okay? Likely probably due to seasonal patterns. The other thing that you're probably seeing there is there's some peaks, right, where the census was rising and falling and rising and falling. And if we were to actually drill down on that visualization, that's representative of Friday and Saturday nights, when we saw a lot of patients that were coming in with critical things to the emergency department, typically something that we see in a hospital. So if you shift your focus on the right-hand side of the screen, that's really where we're using our optimization tools to make recommendations around the number of nurses that should be staffed. So again, we looked historically back at a year's worth of data. We forecasted using time series forecasting to say, hey, this is what you can anticipate in the upcoming months. And we also looked at what in the past had we, what's the number of nurses in the past that we actually had that were required and enabled the care of the demand of that patient census were needed in the future. So if you again look at the right hand side of your screen, you're seeing present day schedule and the optimization tool making a recommendation that we're short staffed at this point in time. It's making the recommendation that we need 15 nurses, but we only have 14 staffed, and so we better get someone proactively on the schedule because we can anticipate that we're going to have a demand that's going to require another nurse. Let's drill into this a little bit deeper. All right, and talk about what I call the right skills to fit the bills, right? We need the right nurse for the job. In the prelude to the actual demonstration, I talked a little bit about how some nurses are certified in those assistive devices. And so by capturing which nurses have been certified and having those skills, we can identify if they should be added to the schedule or not. So what you're seeing right here is the optimized schedule. All right, and you're seeing on the left-hand side of the screen in the table, the list of the nurses, what shift they work, and then in that fourth column, you're actually seeing which of those particular nurses have those particular skills. And the optimized schedule is suggesting that the nurse in row 2 and the nurse in row 4, because they have those specialized skills, they should be added to the schedule. And those highlighted in yellow, I highlighted them so you could really broadly see them. Those are the ones that should be removed from the schedule. All right, so let's shift gears right now, because even though we're solving the problem around proactively identifying the numbers of staff and the right skills of staff to potentially staff a unit, we really want to shift care upstream or outside of the four walls of the hospital. So I want to jump into our next demonstration. And the question that we want to answer here is, can we create a new management tool that not only optimizes the number of staff and optimizes which type of staff should be scheduled to care for patients, but can we also optimize the well care route so that the maximum number of patients can be seen? And the answer is, yes, we can. All right, so let's look at this new use case. And for this particular demonstration, we're identifying all the patients that were cared for by providers in a healthcare organization for a past year, and then we plotted where they lived on a map, and then we grouped them by certain conditions, and then we scored and prioritized potential mobile care routes where a mobile care unit with nurses with specialty skills could potentially stop to provide well care services so they don't show up on the front door of a hospital. Finally, for kicks and giggles, we actually integrated with an external routing resource using an API, Think About Waze, to give turn-by-turn directions for last mile routing. All right, so data sources. Handful of data sources we needed for this. Number one, we needed to know where the patients lived. So again, I mentioned that we had a year's worth of data modeled off of hospital data, which showed which patients were cared for the past year. Then what we did was we also looked at clinical data. So what types of conditions or primary diagnosis did these patients have? Because we wanted to group these patients into cohorts so that each cohort would be visited collectively by specialized nurses that could care for those cohorts of patients. And then we also took hospital demographic information, so where are all our hospitals, also where are our community health centers, and in addition, we actually mapped out some pharmacies too, which you'll see in some of the visualizations. And you could use other data sources as mentioned. You could include social determinants, you could include public transit availability, utilization and service data as well. So let's have a look about how this is going to be useful. So the following really represents all patients that have been cared for by the health system and where they reside. Essentially, the scatter plot for the state of Florida here is telling us where are all the patients, where do they live. So by ingesting that demographic information, we're enabled to be able to pilot each location on this particular map. We also leveraged a SaaS partner here called Loqate, L-O-Q-A-T-E. It's a third-party address processing library that provides address verification and geocoding services so that we had accuracy around where our patients resided. Let's drill a little deeper. Then we wanted to segment our population by the condition they had, and we segmented our population based on 3 conditions. So those patients that had pulmonary problems, those patients that actually had cardiology problems, and those patients that actually had renal problems. So diagnosis like COPD, heart failure, chronic kidney disease, and having the primary diagnosis was key because we wanted to make sure that we were aligning the right mobile nurse resources to those particular cohorts. So the scatter plot that you're seeing here is really just showing the different cohorts and they're color coded. You see a lot of purple because in our sample data, we actually had a lot of cardiology patients or a lot of patients with cardiology diagnosis. Drilling down even further, the visualization on the left is showing the delegation between those cohorts as well. We've also showing here that we're mapping out all of those community centers, the hospitals, and the pharmacies. And then if you look to the right-hand side of your screen, you're actually going to see the concentration of those cohorts or the sites that have been identified through site selection that the mobile routes should take. So I mentioned the SAS site score. So we created these SAS site scores to really rank which areas were the best areas for a mobile medical van with nurses to care for these cohorts of patients could potentially be served. And the site score was really generated off of where's the concentration of patients and how close were they to a particular location. Those were really the key criteria that we used for this. And you can see in the visualization here, there's 5 different areas where there's a lot of patients, cardiology patients in this particular case, located in certain geographies or mapped on geo-mapped on our map, where there would be optimal places for a mobile medical van to be routed. This visualization shows where we are recommending that each of these mobile vans be dispatched to serve the community or cohort to patients. It's the top places to stop, essentially. So you saw the 5 sites, and here they are, and we've also mapped the route that these mobile vans should take to each of these 5 sites to service this large volume of cardiology patients. And to be able to map out the optimal route here, we use the Traveling Salesman Solver. And so for those of you that aren't familiar with this, it's actually a pre-built piece of code available in SAS, meaning you don't need to build it yourself, and it finds you the optimal path to route vehicles. And in this case, it's mobile medical vehicles. We use these in other industry verticals to route trucks, etc. So again, it's determining what is the most optimal or the shortest route for all specified locations before returning to the starting point. Now, a real deployment per Ben, my data scientist that helped me with this, said that we would really use a vehicle routing problem solver because this would allow us to incorporate time windows and distance traveled at each particular stop. But how can we see more patients? It's really great that there's concentrations of these patients, and 5 stops are really great, and we're going to see 472 patients and only travel 247 miles. But what if we were going to do a what-if analysis and consider 3 additional stops? What were our next 3 stops that had still a significant number of patients? Well, you can see from an optimization perspective, if we were to add 3 more stops, we could see 170 more patients and only travel 150 more miles. So the last step, as I mentioned, for kicks and giggles, is we wanted to provide some directions as well. So again, this was an API call made to Project OSRM, an open source routing machine, which is a high performance routing engine designed to calculate the shortest paths in road networks. Again, think about Waze. And we use it in SAS for various applications. Time went fast, but today we did a lot of things. We covered a lot of things, right? We talked about how SAS was used to forecast patient demand based on the associated number of nurses that should be scheduled, based on historical census and anticipated patient acuity. We identified the nurses on staff that had the right skills and recommended them in the optimized schedule. We then shifted and talked about how healthcare workplace is extending beyond the 4 walls, shifting towards more of a well-care concept, but we needed to also consider not only the numbers of staff with the right skills, but now how do we route them effectively so that they can provide access to care to more patients. So we've covered a lot of ground today, and these are all just a subset of use cases that support different operational efficiency workflows. Again, if I've sparked your interest today, Ben and I would love to meet with you and have another conversation and drill deeper and get into the nuts and bolts of how we designed this and how we're solving the problems of operational efficiency in the healthcare workplace. So thank you all today for attending. I hope that you have a great rest of your conference and hope to see you tonight at Universal Studios.
Are there any questions for Miss Heather? You guys? Thank you, Heather.
Well, you have our info, so please follow up if we sparked your interest today.